Okay, everybody, thanks for joining our third CoRDS workshop webinar. My name's Austin Letcher, and I've been with CoRDS for about 4.5 years now. For those of you that don't know, I'm assuming that you do, but CoRDS stands for the Coordination of Rare Diseases at Sanford. And I've been working with Sanford now, like I mentioned, about 4.5 years. Primarily, most recently, I work with a lot of our patient advocacy group partners. So we partner with patient advocacy groups to help them to build disease-specific questionnaires, which I help them with, and help them develop their patient registries. That's what CoRDS is at its most fundamental level, is we're a patient registry for all 7,000 rare diseases. And then I also work with a lot of the researchers to help them get access to that data, make sure they go through the proper vetting process. And we only ever shared the de-identified data with those researchers, but we're also very grateful for all of you that contribute to CoRDS and their data. But I want to introduce you guys to a couple of our other team members here. And Alyssa Mindell is sitting across from me. Alyssa, can you give a quick introduction?
Yeah, hi guys, this is Alyssa. As Austin mentioned, I also work with the CoRDS team. I've been around for a little over 4 years now too. I primarily work with partners and then our institutional review board. So chances are if you call or email in, you're going to be talking to me.
Hi everybody, my name is Ben Forrid. I work really closely with Austin and Alyssa. I'm the program director for the CoRDS registry, so I kind of help oversee the daily operations of the registry, and then I also work closely with Austin and Alyssa to try to define our future strategic goals and help us move kind of in the future, making sure the registry is always growing. So thanks for joining us.
Thanks, Ben and Alyssa. So yeah, we hope that gives you guys a little better taste of who we are at CoRDS, and you know, if you ever reach out to us, chances are you're going to get myself, Alyssa, or Ben. So I think it's good for you to get to know us and have a little better understanding of who we are. So we're really excited to bring this workshop webinar to you today. We think there's going to be a lot of great information on it. And our first presenter we have is Jamie Hoosier, who is the Director of Health Information Management here at Sanford Health. And she's going to talk to you a little bit today about how you can access your medical records. So I'm looking forward to having you guys listen to that. Jamie, can you hear us and can you take control?
Yes, okay, I can hear you. Hopefully you can hear me, and I will start sharing my screen. I'll get this set up here, and I will start the slideshow. I'm gonna make this tweak here. Okay, all right, can everyone see my screen okay?
Looks great to us.
Okay, good. Well, I will go ahead and get started, and thank you for having me today. I'm excited to talk a little bit about how to access and a few thoughts on managing your health information. So as we get started, you know, as you encounter the healthcare delivery system and you are receiving care and treatment, a record of that care and treatment is being created. And that record serves as an important business record for the healthcare facility, the physicians, those providing care. But it is also creating a record of your health information. And it's important for you to understand that while that medical record, that physical, tangible document is a business record and belongs to the facility, the information in that medical record belongs to you. In today's environment, it's very common. Most providers are working with an electronic medical record with some information still being on paper. Generally, you'll find that paper is scanned in or digitized into the medical record for long-term storage. But what's in your medical record is, you know, your journey through the healthcare system. It's going to include your medical history, symptoms, diagnosis, procedures, importantly, outcomes, you know, how a treatment went for you or a certain type of medication, allergy information, test results, provider notes, you know, all that information to help keep track of your medical and health history. But it's also important for you to understand that you have the power and the right to access that medical record. That right is guaranteed to you by the HIPAA privacy rule. When probably the first time you visited a healthcare facility or organization, you were given a notice of privacy practices, or maybe talked to a little bit about that. And that document does tell you how your health information will be used and disclosed. And it also outlines the rights you have. An important right is that right of access, that you can request a copy of your medical record, or you can request to view your medical record. There are a few exceptions to that right of access, but they're rare, and that generally is when there's a more stringent law in place. And oftentimes we see that related to behavioral health or addiction treatment, and those exceptions should be minimal and rare. And also, when you are requesting access, keep in mind you will get a copy of your medical record. You may get that digitally or in paper. That original medical record is going to stay with the facility because that is their business record, and provides that important communication tool and record of care provided to you. But it's important that you feel empowered when you want a copy of your medical record to request access to that. In today's world, the more we know and the better informed we are as a patient and a healthcare consumer, the better choices we can make. And when it's time for you to say, well, I want to figure this out and get a copy of my medical record, I would direct you to the Health Information Management Department. Oftentimes it's referred to as HIM or HIM department. Used to be more commonly known as the Medical Records Department, and sometimes that is still used in various facilities. But if you ask and say, hey, I want to get a copy of my medical records, usually whoever's there helping you can get you to the right team. But that Health Information Department takes that very seriously, and they have a team working on release of information requests and help you get that copy. The first step in that process is generally you will be asked to fill out a form. The form is going to look pretty similar to what's on the screen here today. This is Sanford's form. It's called an Authorization for Disclosure of Protected Health Information. And different facilities may have a little bit of a different name. However, the format is going to probably look pretty similar. And you can generally find that form on the provider's website. If they maintain a website, that's a great place to look for that form. You can visit with the HIM department or call and ask for a copy of that. Or it may be somebody at the front desk that could give you a copy of that form. And it's really handy if you know that you're going to want a copy of your record with your next visit. You can start filling that form out in advance to save you some time. If you're requesting on behalf of your child, just be prepared to, indicate that you are the parent. And as your child, if they are reaching the age of majority and you are still the child's guardian, you may need to provide additional documentation to support that relationship. So part of that is being prepared to prove your identity. You may need to show a picture ID or ask to verify some information. So when that copy is ready for you, that we are getting it into the right hands. As well, if you have a particular custody situation or a shared parenting, maybe you're an appointed guardian, as I mentioned, a foster parent, you may be asked or you will be asked to support that relationship so that the HIM department can feel good giving you a copy of that medical record, and that you can support that role in that person's life. As you're filling out the form, as you can take a look at it there, you're going to want to indicate where you want that information, if that's for yourself or if you would like that sent on to a different location, the purpose, how would you like that information, and then what specific information do you want? What are you looking for? What is the purpose of that request? It may be easy to say I want any and all of my medical record, but that can often be overwhelming and lots of information. It may be more than what you're looking for. So be thinking about, am I looking for my test results? Am I looking for provider notes? And if you're not sure what you're looking for, you know, visit with the HIM department. They're happy to help you fill out that form. If you know dates, those are always very helpful as well. And if you don't remember when you had a particular procedure or test done, you know, ask them. They can help look that up, and they can help fill out that form with you. It's also important, you know, once you're given a copy of your medical record, if they send that to you through a secure method or give it to you in paper, you are then responsible for safeguarding that information and keeping track of it. Another common question we get is, are there any fees or costs associated with this process? Visit with your provider about that, or that HIM department. You know, ask if they charge a fee, and if there's an estimated cost if they do. And don't assume that'll be the same for every facility. That's a good question to ask on the front end. HIPAA does allow the facilities to charge a reasonable and cost-based fee. However, some providers and some facilities choose not to charge patients when they're requesting a copy. So be sure you ask about that as you're filling out that form and working with the HIM department. As far as how long that'll take you to get a copy of your medical record, that can really vary. You know, that can vary on the format that you've requested. You know, it might be quicker to get you the information electronically versus in paper. However, the HIM department needs some time to make sure that medical record is complete and accurate. They will be reviewing that information, making sure it's all there for you, so that when you get that copy, it's what you're looking for. So HIPAA does allow 30 days to process that request, and then they can also ask for an extension if needed. Generally, you know, if you visit with the HIM department and tell them a time frame of what you're looking for, they should be able to work with you to get you that information when you need it. And as well, if you have an urgent request, be sure to let them know, hey, I need this coming up next week or tomorrow in a couple of days because I have a particular visit coming up. They will have a process to help get that information to you in a shorter amount of time. As well, they can send that directly to another healthcare provider if that would be helpful to you as well. The one thing that is important to know is that if you're requesting that medical record be sent to another facility, try to be as specific as possible of where to send that information. You know, if you think of large healthcare facilities, you know, sometimes medical records can maybe float between departments or different locations. So the more direction you can provide in that regard, the better chance it'll have to get to the right place. So that's, you know, you'll fill out a form, you'll have some talk about fees, if any, will be charged to you, you know, how long will that be, what's the format. You'll work with your HIM department to get those pieces in place so you can get a copy of your medical record. Another part of having access to your information and being empowered is patient portals. Many providers and healthcare facilities and systems are now providing a patient portal. And generally that will be specific to that particular provider healthcare system. And it provides a nice electronic means for you to have access to a subset of your health information. Some providers, it kind of varies of how much information they're releasing out through their portal. It's very common to find lab and test results, after visit summaries, progress notes, but that's going to vary by physician or by provider. So take advantage of signing up for that portal and see what information you can get access to electronically. You know, it's great to get your test results through there and have a visit history. It kind of helps you with maintaining that timeline and having a way to look back at the different visits you've had. So a patient portal, you know, it's another way to kind of supplement getting a copy of your medical record. And oftentimes too, sometimes HIM departments can send you a copy of your record right through the portal. So another great way to kind of have access to that information for that particular healthcare system. Just wanted to quickly highlight a few reasons of why it's helpful to get a copy of your medical record. Again, it's really about empowering you as a patient to understand your information. You know, sometimes when we're seeing a physician or, you know, getting a new diagnosis or trying a new treatment, it's a lot to take in. So by getting a copy of your information, it helps you review that and maybe better understand the care and treatment you're being provided. And while progress is being made, there's still challenges with exchanging information electronically. So it's nice for you to have a copy of that information and be able to have access to it. Another important point is it helps you to make sure your information is accurate. You know, unfortunately, mistakes happen and inaccurate information can get logged in your medical record. And by you taking the time to look at that, you can ask and help for those things to be corrected. And as well, you know, it just helps you be a better informed advocate as you venture through the healthcare system and seeing different providers. It can help you avoid repeated tests and procedures, can help jog your memory of things you've had, you know, some time ago. So it's just a nice resource for you as a patient. Another thing to keep in mind as you're thinking about getting copies of your medical records is varying retention periods. Some providers in some states require providers and healthcare facilities to keep medical records for 10 years, 20 years. Some locations keep them much longer than that, 50 or 100 years. So if it's something you've had done some time ago and you're thinking about getting a copy of your medical record, that will be an important question to ask is how far back can I get my information? So kind of keep that in mind. And then also it's helpful for you as you navigate through the healthcare system to keep some kind of a timeline or a medical history. So you at least have the basic information of different visits and contacts, specialties, significant events, findings, or new diagnoses. And that can seem a little overwhelming, but keeping a simple and a manageable process, if that's on a spreadsheet or in a notebook or whatever kind of resource will help you to kind of keep track of your medical history is important. And it's very helpful for continuation of care and as you see new providers. And like I've been talking about, the HIM department or Health Information Management Professionals, the way we care for patients is by helping to care for your medical information. So as you're navigating this journey and wanting to get access or copies, you know, seek out the Health Information Management Professionals or Medical Records Department and ask for help in that process. Our job is to help you as a patient get access to the information you would like. Kind of my last top 5 things as I conclude my portion is you have the right to access and get a copy of your medical record. You are an empowered patient and that is your information, and exercise that right. You may be charged a fee, but that's something to ask about. You just keep that in mind as you're going through the process. The HIM department is there to help. Keep an easy process to track your medical information and health history. And then as you're filling out that form, be specific. Ask for the information you want and get help. And then, of course, my last little point there is just provide enough time so that you can get the complete and accurate information you're requesting. So with that, I can take questions, or if we want to move to the next speaker, I'll leave that up to you, Austin.
Thanks, Jamie. Yeah, great presentation. I'm kind of thinking that everyone listening might get a better idea of what to ask after they hear Mark's presentation too, but I did want to highlight one thing after your presentation, which for everybody else on the call that may not know this, we actually, Ben and I actually sat down with Jamie and recorded a podcast, our CoRDS cast. So I've heard a little bit about this before, and I just loved how you described the Health Information Management Department as really the customer service department of the healthcare system. So I think that's really important for patients to know, and that they can reach out to that department to really help them identify their medical records to, you know, whether it be going doctor shopping, you know, which is really common in rare disease, or whether they just want to retain those records for their reference on their own. So great talk. I think we'll save the questions for the very end. So if you wouldn't mind, Mark, if you'd introduce yourself and take it away. And I think we just need to check on Mark's audio quickly.
Can you hear me now, Austin?
There you are. Yep, you are live.
Wonderful. Well, thank you so much, everyone, for joining us. And that was a fantastic talk prior to mine. It's a hard act to follow, but I think a really good segue. So really quickly, just to introduce myself, I'm a doctor, but probably more importantly for this context, I'm also a patient with a rare disease myself. Those two things are not entirely coincidental. The reason I went into medicine and oncology in particular is I lost my father at a young age to cancer, and then later realized that the reason for his cancer was a hereditary syndrome that runs in my family. I was the first person to realize that, and by the time I did, my dad had passed, as had my paternal uncle and paternal grandfather. So it's something of a family curse, and that disease is called multiple endocrine neoplasia type 1, which is one of the diseases that CoRDS tracks, and we've been very grateful for that collaboration. I work with an organization called Amen Support. You can see our peacock logo there. And then in my professional life, I'm a gastrointestinal oncologist. I run GI oncology at Intermountain Healthcare in Utah, which is sort of like Kaiser Permanente on a smaller scale and covering Utah and the surrounding states. So I wanted to talk to you, again, sort of wearing two hats as a patient physician, but what actually happens when you go to the doctor. I want to kind of lift the hood and look at the engine of an appointment. And I'll start with an anecdote, again, from the patient side. A couple years ago, I was transferring my care from one major academic medical institution to the other, both very respected centers. As I was shifting to the second one, much as we just heard about requests to health information management, I did submit a formal application to have my records sent. The receiving institution said, that's great. We'll need your records at least 8 weeks ahead of time, so one of our doctors can review them and make sure that you have a productive appointment. I said, okay, that's fine. I'm happy to wait. It wasn't that urgent. So the day finally came, and I rearranged my entire schedule to see this one doctor who I was told was the expert in my condition, which again is called MEN1. And this physician walked in the room, and before I could even really get a couple words out of my mouth, they sort of stopped and stared at me and said, oh, wait a minute, you have MEN1. I only treat MEN2. You're going to have to see one of my colleagues. And then they left. And that colleague was not available that day, and I had to come back another time. That was a minor inconvenience for me, but it taught me that you can do a lot as a patient to advocate for yourself. And also, sadly, you can't always assume that records have been transferred appropriately or even reviewed ahead of your visit, and it really is appropriate to speak up as the best expert on your own condition. MEN1 and MEN2 sound the same. They are completely different diseases, so I certainly don't fault that doctor for excusing themselves. But it did, again, strike me on the patient side that was a bit of a wasted visit, and I want to make sure no one else has to go through that, especially if their needs are more urgent. Okay, let me see if I can advance my slides here. Okay, so there's two quotes to keep in mind here. The first of which is, by failing to prepare, you're preparing to fail. That comes from Benjamin Franklin. And we have a second quote from a less famous person. The most powerful force in medicine is the self-advocating patient, and that quote comes from me. In my own practice, I really love it when patients take responsibility, not just for records transfer, but for ensuring that their records have been properly received. I know that sounds unfair. I know, again, you're trusting your doctor sometimes with your life, but the system around records and information transfer, as you've already heard, is extremely complicated, and sometimes the baton gets dropped. And so I would say trust but verify. Make sure that all of your data has been properly sent and received, and that means comprehended by the physician that you're seeing. So again, I have something of a bicameral mind. I think about this both as a patient and as an oncologist. So this is overly simplistic on the patient side. I know patients think about a lot more than, I hope this doctor can help me. But on the right, I try to think about the steps that I go through, especially when I'm seeing a new patient. And this may sound very specific to me, but I guarantee you this is almost exactly the same template used by every doctor across the country, because somewhat sadly, this is the way that people bill for a visit, is these components have to be present. So the first thing that a doctor is thinking or asking for is what's called the chief complaint. I don't really like that language because it already makes the patient sound plaintive by definition. But basically, this is whatever you say, usually as a verbatim quote, whatever you say is the reason for being there. And I don't know on the patient side if everyone's aware of this, but usually you get quoted exactly. So it's very important that you be clear about why you're there as much as possible. Then the doctor will take your past medical and surgical history. It is really important, as was said earlier, that you know this with as much specificity as possible. If you know dates of procedures, that's extremely helpful. Social history runs the danger of becoming just sort of like a checklist of vices. We'll usually ask about, do you smoke cigarettes? How much alcohol do you consume? Do you use illegal drugs? In truth, it should be about a lot more than that. It should be about your career, where you live, where you've lived, occupational history. But unfortunately, this has increasingly just become, do you smoke, do you drink, do you use drugs? So don't be offended if someone asks you that. That's usually part of the social history. Family history, I cannot stress enough. In my family, our pattern of MEN1 probably would have been found a lot sooner if a good family history had been taken. And what that means is not just saying, oh, someone in the family had cancer, but finding out what cancer and at what age of onset. And that is a total game changer in some of these cases, especially with rare illnesses like get registered in CORDS. So again, I would encourage you, I know it's not fun Thanksgiving dinner conversation, as much detail as you can glean about your own family and then pass on to your doctor, you'll be doing everybody a huge service. I call it the tip of the iceberg phenomenon. A couple of times in my career, I've been lucky enough to make a diagnosis and then working out the way in that family, we sometimes find 20 affected individuals depending on the pattern of inheritance. So it's a really, really powerful part of the entire interview. Then it's really common, whether you know it or not, for the doctor to do something called a review of systems. That means sort of casting a wide net, making sure that they're not missing any other symptoms that may seem, inconsequential to you, but again, may provide a vital clue. Sometimes this is only done in writing. We've all been to the doctor and filled out several pages of questionnaires where they typically go, organ by organ. They ask about heart, lungs, kidneys, etc. That is a review of systems. By the letter of the law, it suffices generally to have that scanned in as a paper to a computer file. By the spirit, however, it would be great if doctors had the time and foresight to ask about that. They don't always do that. And then the physical exam. This also has many components for reasons that are truly bizarre. The head, ears, nose, and throat are considered separate from the eyes. And again, I hate to say it, but all these parts are billable. So some doctors, especially depending on how they're compensated, really do pay attention to the fact that they're moving from one part to the other, not just to be thorough, but to make sure that they're getting, their money's worth, which is, I hate to say it, but it is a component of this. Medication reconciliation is either done by the doctor themselves or often done by a medical assistant or nurse and then given to the doctor for signature. This is the legal record that someone has checked on what medications you're taking and also reviewed your allergies to make sure you're not getting something that you're going to react badly to. The assessment and plan is probably the most important part of the whole document. That's where the doctor sums up their understanding of you. That's the assessment. And then outlines what treatment they think you should get. That's the plan. If you're going to read nothing else of your medical record, I would strongly suggest you start or at least focus on this part, because this is really where the doctor distills down their summary of you. And this is where if they get this wrong, your treatment plan could also be incorrect. Then whether you see it or not, often the doctor has to place orders, usually in the computer. It's increasingly rare to see this done on paper, and that determines when you're coming back and what you might have done before that appointment. Billing is something that usually also happens, quote unquote, off stage, and is largely determined by what went into the document. To a really alarming extent, medicine in America is becoming almost as much about the medical record as the care that the record is documenting, because it's how money is made. And all doctors, or almost all doctors, are subject to review of the records by third parties to determine if they've done enough to merit whatever they've charged. And so, again, I hate to say it, but billing does come into the doctor's mind. Have I done enough to bill X level of service? Generally speaking, a new patient visit carries a higher charge because you're getting all this information for the first time. Subsequent visits are usually less in depth and less quote unquote valuable, although I would argue every visit is valuable. And the last thing the doctor is thinking about, and this is really being candid, is time. Virtually every doctor in America, whether they're billed per visit or not, has some time pressure on them because resources are finite. And as I'll explain in just a second, that time is going to vary from appointment to appointment. So I would argue that time with your doctor is invaluable to you, but valuable to other people who are trying to profit off that encounter. If you're lucky, a new patient visit will last up to an hour. There are places like Mayo, where I did my fellowship, where sometimes new patient visits are up to 2 hours. That's far and away the exception, not the rule. I know many clinics where a new patient visit is only afforded 30 minutes, which quite frankly is seldom adequate, but it's what we unfortunately are forced to do. And then a follow-up visit, I've seen them as short as 5 minutes, which again, I think is likely too quick in most cases. Generally speaking, this will run from 15 to 30 minutes. And the reason I'm bringing this up is you sort of have to have a clock in your head too, and make sure that you're getting the most important things addressed first, almost like a triage. What really matters to you to get out of the visit? Make sure that it's addressed up front, or at least in the time available, because the time is truly fleeting. And again, the other thing that can happen, unfortunately, is urgencies or emergencies can arise from the doctor. So whatever matters to you, whatever priority you have going to the visit, try to get it out of the way as soon as you can. Screen time is another complaint that I well understand about modern medicine. Again, almost all of us now use electronic medical records, but the computer itself can become a huge distraction to the doc. Especially if they're seeing, say, 25 patients a day, they usually will put information in as they go, which is good in terms of accuracy, but is bad if they're ignoring you for the sake of the computer screen. And so the way I would describe this is sometimes the medium of the electronic medical record overcomes the message that you're trying to put in the record. There are good things about electronic medical records. It is true, at least for me, that doctors have terrible handwriting. So the era of the manual handwritten record is increasingly fading into the past. There's still a lot of scanning paper into the computer, which strikes me these days as a little bit silly, but it still happens. The problem is we have a bit of a Tower of Babel situation where there's all these different systems across the country that don't necessarily talk to one another. And this again dovetails with the HIM talk from earlier. Unfortunately, you can't assume that if you've been seen in one place and you're going another, that those doctors have access to the same computer system. The way this works is Epic in the top right is kind of like the Coke of EMRs. Cerner on the top left is kind of like the Pepsi, and everything else on here is sort of less popular soft drinks. And again, they're not readily interchangeable, and that leads to real gaps or even mistranscriptions of information when records are going from one place to another. I'm not trying to scare anybody. I just want to be very transparent about these different languages. I think we've probably missed the boat here in that the government has allowed private companies, industry to develop their own brands. And it's in the best interest of those businesses, frankly, especially if they're not the dominant business like Epic, to keep their information proprietary. So unfortunately, I think the horse is a bit out of the barn, and we now have all these different systems. This isn't even an exhaustive list. All these different systems where information is stored, and we don't speak a common language, which is really quite unfortunate. And then finally on this slide, I would say when you're meeting someone for the first time, and again, I hate to say this, assume they know nothing about you. Assume you're literally having to start from square one. But you also have to be wary of what are called chartomas. And again, I'm an oncologist. I treat tumors. I treat things that grow that we don't want to grow. One thing that happens in the electronic medical record, which is truly egregious, is copying and pasting. So to save time, sometimes doctors, and this is somewhat understandable, will just copy huge chunks of text and paste them into a new document. That's great if the information is accurate. It's not great if the information was inaccurate to start with or needed to be updated. A very common example of this happens in the hospital when, let's say, you're on an antibiotic. It can appear in the chart like you're on the 4th day of the antibiotic for 7 days in a row, just because someone isn't updating the number and they're just copying and copying from that 4th day. So that's something that we all have to be cognizant of, both as physicians, but also as patients and consumers. Because this is a rare disease talk, I did want to use the metaphor of horses and zebras, which is probably familiar to you. Just in case it's not, we are taught in medical school, we're taught about all these different esoteric diseases, some of which we may never see in our careers or only see once. And I've certainly been on the patient side of that. The adage that we're taught, though, is when you hear hoofbeats, think horses, not zebras. And what that means is if someone comes into you and they have lung problems or a new cough, you should be thinking about common stuff like acute bronchitis or pneumonia, and not more esoteric conditions like, say, cystic fibrosis. So the problem with this approach, of course, is that works great for many people in the population, perhaps even most of them. But if you're only thinking about horses, you will miss the zebras. And again, as someone with a syndrome myself that runs in about 1 in 30,000 people, I've actually been in the somewhat awkward position of educating my own doctors about my condition. And you may think they're just affording me professional courtesy, but I assure you it's more the fact that many of them have never seen an MEN1 patient before, and I'm actually semi-responsible for bringing them up to speed. I know that's awkward for you, or can be. I would say that your health matters more than the risk of quote-unquote offending the doctor. I think the age of paternalism, where doctors just tell patients what to do, is over. Frankly, it never should have gotten started. But with medical ethics, we always respect autonomy first, meaning you're the boss. We're just there to help you. And that really is a dynamic that I personally think is changing or has changed. But don't be afraid to make sure, or again, verify that your doctor understands exactly what your potentially rare or vanishingly rare condition might entail. I want to embolden everybody. You're the expert in your own case. No one else has been through exactly what you've been through. Even reading the record in great detail is only a sort of secondhand experience that you've been through, that you've lived. I tell my patients all the time, listen, you inhabit your body 24/7. I get to see you probably the most often. I see my patients weekly. Often I just get to see them every 3 months. Sometimes I only meet someone once. And that is your chance to really tell your story to the doctor. There's tons of time pressure. So one thing that does help, that is kind of a practical tip, is if you do have a complicated history, most doctors, myself included, love it if you type that up ahead of time. And that, again, saves valuable time in your conversation, allows you to focus on the present rather than the past, because the first visit is all too often consumed by discussing all of your past details, which is appropriate, but then maybe not even getting to your most pressing concern in the present. And doctors are within their rights. If they think that you've run out of time, they're within their rights to bring you back. But particularly if you've traveled somewhere for a second opinion or specialty care, that's not always convenient to do. And as I made an example of my own case, I was lucky in that I lived and in fact worked at that second medical center. So I was able to come back, basically whenever I could. Many people are not that lucky, and also these visits cost money, and so you really want to get bang for your buck. So with that, I will stop, and I think Austin was going to open it up for questions to all of us.
Thanks, Mark. Yeah, that was a great presentation. I always enjoy hearing your story and your perspective, both as a physician and a patient, and really a patient advocate. So now's the time when our participants on the line can use the chat feature and ask their questions, both to Jamie about accessing their medical records, and then also Dr. Lewis about using those records to inform their doctor or their patient. But just to kick things off, I kind of have a question that applies to both of you. So when patients are accessing their medical records, often, as you guys probably know, they have complex histories, could potentially have multiple misdiagnoses, and that translates to a hunk and stack of paper that they would have to potentially bring into the doctor. So my question is two parts. One, Jamie, does Sanford Health or do hospitals work with patients to get that information on a thumb drive or a CD, and how do those patients approach that? And then two, Mark, can you go to your doctor with a thumb drive of information, or does it have to be sent, like you said, 8 weeks ahead of time? So Jamie, do you have any input on that?
Sure, I can comment. Yes, I think when you go and ask for a copy of your medical record, you can ask for a form or format that works best for you. And so at Sanford, that can be on a USB drive, CDs, which you don't see as common anymore, but you can ask for that information electronically. That may even be sent to you through a secure email, but just ask your provider what options are available. It may even be something they can push to you electronically through their portal if that's available and you have signed up for that service. So it's just a great discussion question. Paper is a good old standby, but what can they do electronically as well?
Yeah,
thanks, Jamie.
I agree.
Go ahead, Mark.
That paper is cumbersome, but it's sort of the ultimate backup option. I'll often encourage patients, if there's just overwhelming prohibitive volume of paper, to take pictures. Most of us are lucky enough these days to have phones with cameras. That's very powerful. My caveat about USB is actually at my institution, we take cybersecurity so seriously that we actually can't even use USB drives ourselves for fear of uploading a virus or malware. So that's actually more common than you might think. Again, we're entrusted with data, your data, and breaches of data security are extremely serious and can result in an institution losing its accreditation or its ability to get reimbursed by organizations like Medicare. So if anything, they err on the side of caution. HIM departments and cybersecurity departments are very, very vigilant. We're, as docs and healthcare staff, we're encouraged not to be downloading attachments off email if we don't know what they are. And there've been well-publicized cases of viruses and malware spreading like wildfire through EMRs and resulting in information getting out that should be private. So long story short, paper is a good standby. I realize you don't want to bring boxes and boxes. I had one patient at Mayo literally bring 6 boxes on a dolly. That took me about 4 hours to go through. Most of the time, though, you don't have to send things 8 weeks in advance. Usually the receiving clinic will ask for your records a little bit in advance, mostly to make sure that the appointment is appropriate for you, almost as like a screening mechanism. But again, don't necessarily assume that the doctor has read all or even any of that when you walk in the room.
Awesome. Thanks you guys. We've had a few questions kind of pour into the inbox. So I'll start with the top one. And I think, Mark, this is a question for you from Adam. In terms of copying and pasting, he's had his daughter's MRI report show that she was a boy because the radiologist had applied the wrong template. Do you know if that copy and paste kind of nuance is common in the radiology world, or is it really something that's just widespread throughout all of medicine?
Well, again, I don't want to denigrate my radiology colleagues, but they're kind of the unseen heroes along with pathology, at least in oncology, and they're often having to read dozens of scans a day. And my point is, they'll often rely on transcription software. So, in fact, I think every radiologist I know does this. They talk into a mic, and they have certain hot text or verbal cues, then populate what they're saying into the medical record. And so it's very common. The gender misattribution is probably the most common mistake I see. In fact, I had one patient get so offended that the radiologist had called him a woman that he refused to ever go back to a particular facility, even though I tried to explain. I thought it was an honest mistake and didn't ultimately affect his care. But I understand how those things undermine confidence. You think, well, golly, if they got my, how I identify as a gender, if they got that wrong, what else did they get wrong? So because the radiologist seldom sees you in person, if you ever have a question or even a correction about your radiology report, I would say you're within your rights to bring that up to whatever doctor you are seeing directly. And usually they can submit a request for it to be addended. Another thing that will sometimes happen is a lack of congruence between sort of the main body of the report and the summary. So almost every radiology report sort of goes line by line through all the organ systems that are visible on the scan. And at the end, there's a summary. And sometimes, one word can sway the impression one way or the other, like no, or, yes. So if you say no pulmonary nodules, but up front you've described a large lung mass, that's a mistake. And that needs to be corrected. So again, don't be too shaken by those mistakes, because you have to realize how those reports are generated. But you're also well within your rights, and I welcome my other speakers' comments here. You're well within your rights to have that corrected if you think it's a mistake.
Yeah, this is Jamie. You definitely can request to have that corrected. Again, that's one of those HIPAA privacy rights that came to us several years ago, that we have the right to request that information be amended or corrected. So I definitely, you visit with your provider, contact the health information department. It'll be another form you'll need to complete and kind of a request process, but they can help you get that corrected.
Thanks, guys. It looks like we have another question here, and this is for either Jamie or Mark. So when the data in the medical record is complex and not easily understood, is there anything a patient or a parent can do besides discussing with the providers in further detail?
I guess at the root of the question is just seeking better understanding. This may actually be a much larger issue than just talking about health records. And whoever posed the question, I'm happy to clarify if I got this wrong. But the internet is probably the best and the worst thing that's happened to health information. On the one hand, it's really kind of leveled the playing field, even for docs. Like when I was in medical school, and I'm probably showing my age, if I wanted to look something up, I would have to go to a library, and the library would have to have the article I was looking for. Now it's almost all digitized and largely available if you know how to search. So PubMed, PUBMED.gov, and maybe we can send out that link later, is sort of the holy grail search engine for the medical literature. It's very hard to get things in there that are inaccurate. The more tempting thing to do is just to Google a given condition. The problem there is that Google is a system that can be gamed, and people can pay money to have their search results bubble to the top, even if they're not the most reliable. And this is unfortunately a whole sort of cottage industry of people taking advantage, particularly of cancer patients, which just boils my blood. But they do it because it works and they can make a lot of money. And my point is that you can't trust everything that you read. You have to be very savvy as to the source. I always push my patients away from Google. It's fine if you're looking up what restaurant to go to, but it's very precarious if you're looking up crucial health information. PubMed.gov is you can tell by the suffix, is a government-run database of the medical literature, which is also constantly evolving. So if you are interested in your condition, I tell people to go there. The National Institutes of Health also runs a very good descriptive database of rare conditions, as does OMIM, which is OM as in Mary, IM as in Mary, the online Mendelian inheritance matrix, I think is what it stands for. And that's a sort of a globally accepted record of all these rare genetic diseases like I have and many of you probably have. So again, a long answer, but hopefully one that was at least partly helpful.
Thanks, Mark. This is another question that kind of directed to you, I think. Carissa wants to know if it's worth it to see a specialist rather than your family doc for a rare disease. She's worried about information being spread across multiple doctors because she's had some problems in the past with different offices not really communicating well.
Yeah, there's really two parts to this question. One of which is making sure that your primary care doctor understands your condition. And secondly is communication between offices. So I'll tackle them in series. For starters, not to play the sympathy card, but I think primary care doctors have a very difficult job in terms of breadth and volume. And full disclosure, I'm married to a primary care doc. My wife is a pediatrician, and I think she does a phenomenal job taking care of patients who can't always talk to her directly in the case of infants, and she has very little time to do it. So she is routinely given 15 minutes to see a child, and in that time has to cover whatever the acute problem is and all their preventative health like vaccinations and such. So I'm not saying that doctors, you need to be crying about it, but primary care doctors have a very tough task. So again, most primary care docs will be very grateful if you provide information about a rare condition. Again, when I first got diagnosed or self-diagnosed, my primary care doctor really didn't know anything about my condition, and thankfully was at least receptive to me getting the testing, even if they weren't certain that that's what I had. So as far as the value of seeing a specialist, I know it puts you in a weird spot, but it's definitely worth asking the primary care doctor themselves if they think a specialist is indicated. Most people, if they're in any way unsure about how to take care of you, welcome an expert opinion. There's not a doctor on earth who knows everything about every condition. That sort of breadth and depth is just completely impossible. And we absolutely rely on each other. Even in my specialty of oncology, I'm subspecialized in GI. If I see a breast cancer patient, I send that to one of my colleagues because I know I'm not best suited to take care of them. So that sort of sharing, or at least the spirit of sharing, is really important. The mechanics of doctor offices is kind of a whole other discussion. The way information is transferred between them is sometimes very clunky. We may be the only industry keeping the fax machine alive at this point. And again, realize, without throwing anyone under the bus, it's probably not your doctor operating the fax machine. They probably have people to help them. Because again, you can't really these days just start a solo practice, hang up your shingle, be a good doctor, and run all this documentation, records transfer, and billing. So most people have people to help them, and I don't know where you had a bad experience, but I wonder if it wasn't sort of a failure of those mechanics. I know it's tough to separate the physician from the practice. I've seen great doctors in I've seen great doctors in terribly run practices, and I've seen not so great docs in wonderful practices. So you have to be kind of savvy enough to tell the difference. But to your initial question, if you have any doubt or your primary care doctor admits, hey, listen, I've only ever seen one of you, a specialist opinion may well be warranted.
Thanks so much. We're kind of coming down to the end of time here, so I want to be respectful of everyone's schedules. Big thanks to both Dr. Lewis and Jamie for joining us today and for sharing their wisdom and information to try to help the rare disease community. One individual, Adam, did ask if the recording will be released for other folks in their community that weren't able to join today. The short answer is yes. We will be, this whole thing has been recorded, and we will be uploading it to YouTube, and we will be sharing that link out afterwards. So we'll make sure to email all of the attendees a link to the recording afterwards, and please help us spread the word. We really appreciate it, and thanks so much for your time. Before we leave, one last kind of, I guess, selfish plug is that in a few weeks, May 9th, 10th, and 11th, the Sanford CoRDS team is hosting a rare disease symposium. It's our annual rare disease summit here in Sioux Falls, South Dakota. You can go to our website at sanfordresearch.org/CoRDS and find it on our events page. It's a free event. As long as you can get yourself to South Dakota, we will feed you and take care of you and give you a great symposium. It's a 2-day event. The Friday is a scientific day where there'll be a lot of talks from different researchers and medical professionals throughout the rare disease community. And the Saturday event is a community day. And so I know that Dr. Lewis, one of our panelists, has been a presenter in a past iteration of the Rare Disease Summit. And this year, Jamie Hoosier from our RHIM will be presenting on some of the same topics she talked about today. So please put that on your radar, and if you're able to join us, we'd love to see you. Austin, Alyssa, do you have anything else to wrap it up?
Yeah, I guess I'd make one more plug. Again, big thanks to Jamie and Dr. Lewis for joining us today. But if you guys are looking for more information like this, we do host a monthly CoRDS, a podcast where we get together with patient advocates and researchers or physicians and focus on kind of building those relationships between the patients and the researchers, which I think we at CoRDS think is so important. So again, I'd encourage all of you to reach out to us. I'll put our information back up really quick. You can call us at 1-877-658-9192, or you can email us at CoRDS, that's CoRDS for Coordination of Rare Diseases at Sanford, at sanfordhealth.org. So we look forward to hearing from you. If you have any other suggestions on topics that you'd like to hear, please send them our way. We want to hear from you, and we want to know what information we can help you gather. And being a part of a large healthcare system, it's easier for us to kind of lean on individuals within different departments here. So thanks again. And if there aren't any other questions, I think we'll just close it here. Again, Jamie and Mark, thank you so much both for being here. We look forward to connecting with you in the future.
Thank you.
Thanks, everyone.
Have a great day, guys.